Now, the question is like the speaker may not have enough time to finish all the talk. If that's the case, please refrain from asking questions. You can ask questions later on during the what you call tumor board, the breakout session. One important thing is that during the tumor board, we would like the participant to participate in the discussion. That way we can go back and forth with what we have. And what we would like to do is present a couple of cases as a sample. And then during the breakout sections, what we like to do is if you have any interesting cases that are of educational value, some controversy or some advice, we would like you to present those cases. You don't have to have slides or anything. You can just stand up and talk. And we will try to discuss that matter and see whether we can help out with the scenario. During the tumor board, the participant will be asked a couple of these multiple choices questions. Those questions are not to test your knowledge, but it is basically trying to assess what are the popular treatment here and how the staging and everything got work here. So you will be giving the clicker, and I'm sure you have a sample of a clicker. And these are the clicker, and they will have a choice, and you just select the number that you think that is going to be the right one or whatever you think appropriate. But it's very important that you turn the clickers when you leave the conference, because we have it in what you call itemized numbers, so we have to be careful with that. There is also an evaluation form in the back, and please make sure when you leave you enter the evaluation form and enter the question and answer, because that way we will have the clue of what will be appropriate for the next section. So let's to begin. I would like to welcome Dr. Tete Chi, who is the chairman of the Finland Group of Hospitals, to just give you the little bit of introduction. Dr. Tete Chi. Mic connect with her.
Distinguished guests and participants, colleagues, ladies and gentlemen, good morning. It's a great pleasure and honor for me to give my warmest welcome and sincere thanks to all of you who have come together here today from various countries for your cooperation, which has enabled us to conduct a highly fruitful ASCO Multidisciplinary Cancer Management course here in Myanmar. First of all, on behalf of Finland Group of Hospitals, I would like to thank ASCO for conducting ASCO MCMC in Myanmar, and all the speakers for taking your time off from your busy schedule to share your experience and expertise at this conference. I also wish to thank Professor Newton, Professor Rimera, and Professor Soal for devoting your time and effort on coordinating this great event. And I would like to express my gratitude to co-sponsor Uong Koen and Donandan Thuy, the chair and vice chair of Cambodia Group of Companies. It's an honor for us to welcome all the participants, and I believe this ASCO MCMC will bring fruitful outcomes regarding treatments and care for cancer patients, and I'm sure this conference will give great benefits to all the participants as well as our people. Thank you.
Next, I'd like to invite Dr. Rimera to give some introduction remarks on this meeting and this gathering. Dr. Rimera is the president of the Myanmar Medical Association, and he's a professor in hematology. Please come.
Thank you. Good morning, ladies and gentlemen. It gives me great pleasure to have the opportunity to address you this morning at the ASCO Multidisciplinary Cancer Management course, jointly organized by the Oncology Society of the Myanmar Medical Association and ASCO International and sponsored by the Penlong Group of Hospitals. I believe this is the first time ASCO International has come to Myanmar to hold such a course, and I would like to welcome all the members of the ASCO team and thank them all for making this cancer management course possible. Today, indeed, is a landmark occasion for all doctors caring for cancer patients in Myanmar. ASCO, or the American Society of Clinical Oncology, is a professional organization representing physicians of all oncology subspecialties who care for people with cancer, founded in 1964 with worldwide membership exceeding 30,000, all united by the common concern for the patient with cancer. Today, ASCO is a world-renowned organization which holds many conferences on cancer, publishes journals, facilitates the education of doctors involved in cancer care, and collaborates with medical and research organizations worldwide. Through ASCO International, it has held many cancer management courses like this one in many developing countries. ASCO has been highly successful in advancing and disseminating medical knowledge and contributing greatly to the improved diagnosis, treatment, well-being, and longevity of hundreds and thousands of fellow citizens with neoplastic diseases, and to aid in the prevention of many others. We are indeed very proud and honored to have with us today representatives of such an esteemed organization. The Myanmar Medical Association was founded in 1949. It is a voluntary, non-profit, professional organization, and the main objective is to promote high standards of medical practice and ethics in Myanmar. It is an umbrella organization for many specialty societies, including the Oncology Society, and its main activities are educational, and every year we hold many conferences and meetings with international participation. We also organize CME courses, talks, and lectures throughout the country. In recent times, we have also been taking part in public health programs like tuberculosis, malaria, sexual and reproductive health, and youth program. Cancer is a very important disease for all of us. In Myanmar, the leading causes of death are still infections like malaria, tuberculosis, and HIV/AIDS. However, cancer is catching up very quickly, and as the prevalence of infectious diseases are coming down, non-communicable diseases will become the leading causes of death in the near future. And among the non-communicable diseases, cancers rank second after cardiovascular diseases at the present. 11% of deaths in Myanmar are due to cancer, and death rates from cancer in Myanmar, men and women, stand third and fifth highest in the Southeast Asia region. Cancer-related deaths in developing countries are expected to double within 2 years. When we were medical students, and that was several decades ago, the diagnosis of cancer would mean, for many patients, an incurable condition, pain, suffering, catastrophic costs, and miserable death. That perception still exists for many people in this country. Science, however, has made considerable advances. Today, we understand the biology of cancers a lot better, and there are many new treatment modalities. However, advances also mean more sophisticated equipment are necessary and more advanced diagnostic tests required. Many new treatment regimens have become available. This means oncologists, pathologists, radiologists, and others would also need to be trained in modern methods. Nurses, technicians, and other paramedical staff are also required as team members. This means a lot of investment in the field of cancer management, human as well as material resources. In the economic hardship Myanmar has experienced during the past 2 decades, however, we have not been able to keep pace with all the advances, and at the same time we have had more cancer cases in hospitals all over the country. Physicians have had to manage patients with many limitations. However, they have done their utmost in caring for cancer patients with whatever they have. And I would like to salute all those doctors and nurses who stood by their patients during these difficult years and cared for them. For the practice of medicine is not about Not always about curing, especially in cancer management, but about caring most of all. Now times have changed. The country has opened up. There have been more investments in the healthcare sector, both in the public and private sectors. Doctors are now free to travel and develop contacts and make networks and exchanges with international agencies. It is an opportune time to catch up and to try to provide the best care for patients with cancer. In the past, many patients who can afford travel to neighboring countries in an effort to obtain the best possible care, and most of these patients were cancer patients. Now, with recent developments and improvements in the healthcare sector, all patients will have a chance to get the best possible care inside the country. And I would especially like to thank all the faculty members of the ASCO International team in helping us to provide the best care for all patients with cancer in Myanmar. Desperation is what most cancer patients develop, and hope is what they look for. But hope alone is not enough. And I'm sure all of you today will be able to give not only hope, but the best possible care for all patients with cancer. I would especially like to thank the organizations of this multidisciplinary cancer management course, and especially to Dr. Mutan, whom I knew many, many years ago as a very bright elder brother, to Professor Dr. So Aung, my colleague, and especially to Dr. Zoto and Dr. Teteji. Thank you very much, all of you. Thank you again.
Thank you, Dr. Rimra. I think the next person that I would like to invite is Dr. Soang. He's the president of the Myanmar Oncology Society, and as you well know, he is well-known oncologist here in Myanmar. Dr. Soang.
Thank you, Professor Mutan, for a very, very kind introduction. And good morning, our distinguished guests and my colleagues. And first of all, I would like to warmly welcome our faculty member who have come all the way from their home country to us to share their very invaluable knowledge and experience with us today. And we deeply appreciate your support for this MCMC course. And as a result of concerted effort by ASCO and Penong Group of Hospital led by Dr. Professor Muta, Dr. Zoton, Dr. Teteji, and MMA, Myanmar Medical Association, and Oncology Society, our dream has come true today. And this is a historical landmark, and this is a very important step, tremendous step forward, and I'm sure this course will provide us with much needed boost to implement the very effective multidisciplinary cancer management system in our country. And actually, this concept of multidisciplinary cancer management is not new to us, but the implementation is very disorganized and ineffective in the past. And actually, we started our oncology specialty way back in 1958 when we first established our radiation oncology center in the country. And since then, we have had few more cancer centers in the country, and up until at the present, we have 8 government centers and quite a few private centers. And out of private center, this Penlong Center is the only one which has both radiation and medical oncology facility, and this is a very good one indeed. We have very few cancer centers actually, given the big size of population. We have a population of, we used to have 60 million in the past, but according to the latest census in 2014, we had just about 51 million. And anyway, we only have very few cancer centers, combined private and public, and you can count on your fingers. And these centers have to serve a population of this big size, about 50 to 60 million. You can just imagine the workload. And you can just imagine how high the patient volume is and how heavy the workload is. So it's overwhelmingly difficult. And on the other hand, we have very limited resources, both in terms of human and material resources. And so this multidisciplinary teaching course is very important, especially what I would like to come out from this meeting is resource appropriate guidelines or something like that, so that will be useful for our country to be used. And although despite these limitations and difficulty in our country, we did have some scattered efforts in the past, over the past few years, at organizing these multidisciplinary cancer management meetings and clinics. And for example, we do have regular weekly cancer joint clinic between Oncology Center in the Yangon General Hospital and Facial Maxillary and Oral Medicine Plastic Surgery Department on weekly basis. And we do have monthly regular clinical meetings for each allied specialties where we can present our cases and discuss the management of those cases. And these are not specific for cancer management, and we do not have specific joint cancer clinic at the moment. But we did have one when I was in the service, government service, and we did it every other week at the Yangon General Hospital. And then we also did have one gynae oncology multidisciplinary tumor board at the Central Women Hospital. It was in the past. And for some reason uncountable to me, these were not sustainable. And so what happened is that the patients suffer from lack of these multidisciplinary management causes. And they were and they are deprived of the benefit of this multidisciplinary management. And the patients suffer from lack of cooperation and coordination between pathologists and clinicians, and from lack of coordination and cooperation among the clinicians themselves, and also among the different allied specialties as well. So as you all know, proper diagnosis, pathological diagnosis, proper staging, and proper choice of modality of treatment, and proper sequence of treatment is very important. They are very important components of multidisciplinary management, and this can make the difference between life and death when it comes to cancer management. So this is especially true in today's era of personalized medicine. So it is high time that we join our hands together, we scientists join our hands together and implement, with the support of ASCO and international organization, implement an effective multidisciplinary management clinics and meetings. And I do hope that this MCMC course will go a long way in driving this message home and will in helping us implementing and very effective multidisciplinary management for each and every cancer, especially those 3 cancers which we are going to talk about over a couple of days, say breast, say colon, and lung cancer. So I would like to especially thank ASCO and international other experts from different countries who come over here to organize this course. And with this remark, I would like to conclude my presentation of MCMC in Myanmar. Thank you.
Thank you, Dr. Seo. The next, I'd like to invite Mr. Doug Bao, who is the Senior Director of the International Affairs of American Society of Clinical Oncology. And basically, he's responsible for spreading expanding the knowledge all over the world. Doug, would you be glad to come in and give a talk?
Great. Well, is this working? Fantastic. So first of all, I just want to thank, on behalf of ASCO, Dr. Mio, Dr. Su Ong, colleagues, the partner organizations to pull together this course. Thank you so much for inviting ASCO. It's really our honor and privilege to be here and to work with all of you to help improve cancer care in Myanmar. Just briefly, I wanted to see if we could do a show of hands. I'm interested to see who is in the audience. So if you are a medical oncologist, can you raise your hand, please? Great. Fantastic. Radiation oncologist, can you raise your hand? Fantastic. Surgeons, can you raise your hand? Great. Nurses, can you raise your hand? Excellent. Fantastic. Pathologists, do we have any pathologists? Excellent. Now I'm going to start offending groups because I can't think of any registries, cancer registries. Well, I think that gives a very good sense of the multidisciplinary group that we have here. And my advice to you as you go through the next 2 days is to think about what changes you can make in your practice as you listen to the talks. Change is not always easy. It can be difficult, but if you start with small changes and then build from there, it will be amazing what you can do in a short time. So let me just very briefly, I know we're short on time, go through a little bit of what ASCO and ASCO International is as some background. So ASCO is today an international organization. A third of our membership is from outside the United States, and actually a majority of the attendees that come to our meetings come from outside the United States. So we take very seriously our responsibility, excuse me. So here you can see, it's a little hard to see, but a map. The dark colors are where we have members around the world. And we take very seriously this global responsibility to work with our members around the world to improve cancer care. I hope that those of you who are not currently ASCO members would consider joining ASCO. A few opportunities here to bear in mind. One is that if you are still receiving your training on oncology, you can join ASCO for free. And so this is a way to join the community at no cost and to get to know ASCO a little bit better and pursue those opportunities. We also have a reduced membership category for countries like Myanmar, and I can give you more information about that during the break. I think for Myanmar it may be $175 a year to join ASCO in this category. So just very briefly, a few years ago ASCO launched ASCO International, and this was really a recognition of the rise of cancer in countries like Myanmar, low and middle income countries that are seeing a dramatic shift in the disease burden. And the strategy here is to link up ASCO members in countries like Myanmar with ASCO members outside of the country to share knowledge through courses like this and other programs, which I will describe very briefly. So ASCO International really has three pillars. One is to improve quality of care. We also aim to accelerate innovation and research through research grants and other opportunities, and also to support professional development of the oncology community. So we improve quality of care through training courses like this. We have a few other programs which I'll touch on very briefly. So we have training courses, palliative care, cancer prevention. We're launching a new course this year to train primary care providers in aspects of cancer control, covering early detection, cancer prevention, other topics that they can put into their practice. We have a program called the International Cancer Corps, which sends ASCO members to specific hospitals in low and middle income countries to do a comprehensive development of their oncology capacity. And the Best of ASCO program shares highlights of the ASCO annual meeting in different countries around the world. In terms of supporting research, we offer a training workshop on research skills, which certainly we can explore whether there's interest in Myanmar for such a workshop. And we also provide research grants to help support research in countries like Myanmar. And in fact, through this program, the Innovation Grants Program, we're funding Dr. Theda here in Myanmar, who is doing cervical cancer research, and as well as other investigators in other low and middle income countries. This is a program through our Conquer Cancer Foundation, and we're very pleased and privileged to have the chair of the foundation here with us today, Dr. Penley. He'll be speaking later on today. And I encourage you to talk to me and talk to Dr. Penley about opportunities through the foundation to support your research ideas. Here are some other Conquer Cancer Foundation research awards and opportunities. And then finally, in professional development, we have the IDEA Award, which is for younger oncologists who are looking for mentoring opportunities and ways to visit, to participate in the ASCO annual meeting. So we have just concluded the IDEA round this year, but we will be starting up again next year. And those of you who are in the earlier stages of your oncology careers, I encourage you very much to consider this, this award. And the Life Fellowship provides an opportunity for you to spend time with your mentor at their institution in the United States or Canada for a longer duration, for a year. There are very few of these. We do one or two of these awards each year, so it's very competitive, but it's a fantastic opportunity. So just finally, encourage you at the end of the course to complete the evaluation form that helps us to improve these courses and understand what is working and what is not working. So please provide your feedback. And that's it. There is my contact information. And please talk to me during the breaks. Send me an email. I'd be happy to give you more information about ASCO membership and other opportunities through ASCO International. So thank you very much, and look forward to the next few days. Thank you.
Thanks, Doug. Appreciate that. Okay, now I think we just start going to the main topics. My name is Myo That. I'm basically from the, I worked as an attending physician at the Baltimore VA Medical Center, and also as a assistant clinical professor of medicine at the University of Maryland Greenbaum Cancer Center. The topic that I'd like to start today is about screening colorectal cancer. I'm sure a lot of people know about it, but I thought it would be nice to refresh it. As you well know, cancer accounts for 1 in every 8 deaths in the world, and in 2012, we estimated 14.1 million cases of cancer diagnosed and 8.2 million deaths. And we expect that to increase significantly in number at the alarming pace. And if you look at it, more than 60% of the cases occurs in the low and middle income countries. And part of it is because of aging population, and part of it is the adoption by these third world countries into these Western lifestyle, the bad lifestyle, as you well know, having poor diet, increased obesity, physical inactivity, and smoking. And that basically causes the increase in the cancer in these third world countries, particularly since they're not doing any prevention or screening or increased cancer awareness. On the other hand, in the United States, in the Western country, we found that we have significant progress in colorectal cancer. The 5-year survival rate, in fact, has definitely increased, increased from like 46% to 48% in 1975, all the way to 2009. If you look at it, it has significantly increased to 66%. This is the same is true with the mortality. The cancer mortality has dropped down to 29 per 100,000, all the way to 16 per 100,000. And this is primarily because of increased awareness of cancer, and also because of the proper screening and follow-up. As you well know, the progress of cancer, starting from normal mucosa all the way to cancer, is relatively straightforward. Starting with normal cells, increased proliferation of hyperplasia, to small adenoma, to large adenoma, and finally to cancer. And all these steps are basically caused by mutation in these genes. And we are finding more and more genes in that regard. And so the interesting thing is it takes about 10 years from the normal to develop into cancer. So that's one of the reasons why we recommend colonoscopy once in every 10 years for a normal individual. However, it is not true in HNPCC or hereditary non-polyposis coli, where it can develop within 2 to 3 years. So in these people, you need to do colonoscopy every 2 to 3 years. Most of colorectal cancer, however, is sporadic. It occurs as a random mutation of the genes and chromosome, and only 15% is caused by hereditary colorectal cancer. And what are the risk factors? Naturally, personal risk is the most important one. If you have an increase in, if you have colorectal cancer, there's significant increase in one to develop another one. If you have a family history, like a first-degree relative who developed cancer, then the chance of you getting another cancer is higher. Diabetes is very interesting because it increases insulin, and as a result, it increases the insulin-like growth factor that stimulates carcinogenesis. Alcohol and smoking, as you well know, are not good at all because they increase colorectal cancer. Diet, particularly red meat and low-fiber diet and low-fruit diets are very increase in causing cancer because it releases nitrosamine in the body system. We have found now that obesity and physical inactivity are very important because there is significant increase in not just colorectal cancer, but also in other cancers. This is a graph, the study done by one of the large cooperative group that looks at the body mass index and relapse progression-free survival or the increase in survival. If you look at the green graph, you notice that it is caused by underweight people. On the other hand, if you look at the next graph, you find that it occurs in obese patients. So naturally, having overweight is not really good at all. And the same is true with physical activity. And people who do regular exercises have better survival than people who are just not doing any exercise at all. Of course, other risk factors include inflammatory bowel cancers. The inflammatory bowel cancers got 40% of them developed in colorectal cancer, and that includes ulcerative colitis and Crohn's. And ulcerative colitis, you have to be aware that it takes about, particularly for 10 years after pancolitis, you have to be started worry about getting cancer. And these people need to be aggressively followed with the periodic colonoscopy, and if there are any dysplasia, they need to be referred to a surgeon for prophylactic colectomy. Crohn's disease, however, is segmental, so you can do a segmental resection based on the changes. And these are other hereditary colorectal cancers. Of course, among them, the most important two are hereditary non-polyposis coli and familial adenomatous polyposis. Hereditary non-polyposis coli cancer, or Lynch syndrome, occurs in about 4 to 10% of the colorectal cancer. It can also cause other cancers like endometrial, biliary tree, stomach, small bowel, ovaries, and renal pelvis. The lifetime risk for developing is 80% or so, and it's usually caused by mutation in these DNA mismatch repair genes, and particularly MLH1, MSH2, MSH6, and PMS2. And you can identify these by doing immunohistochemical analysis of the mismatch repair proteins or the polymerase chain reaction for analysis of microsatellite stability. Any of the person who fits into Amsterdam or criteria of Bethesda guidelines have to be analyzed for HNPCC. I'm not going to go through those guidelines, but briefly, it's basically if you have a relative that has a cancer at a younger age, then the risk of you getting is very high. The same is true of familial adenomatous coli, and they usually present with multiple coli. throughout the colon, and these almost 100% will develop into cancer. And usually it goes from Mendelian autosomal dominant and from the germline mutation of the adenomatous polyposis gene located on the long arm of the chromosome 5. They can also develop other cancers, such as small bowel, papillary, and pancreatic cancer. Of course, you need to screen those people for colorectal cancer. And what are the screening tools? We have fecal gut blood, flexible sigmoidoscopy, CT colonography, and colonoscopy. I'm not including barium enema since we are not using anymore for the screening process. Fecal gut blood testing is low cost, it's very simple and very cheap, and it can be done at home or in the physician's office. But it requires 3 separate stool specimens. You can't do 3 tests on 1 specimen. That's not really 3 tests, but you really need to have a 3 separate stool specimen. The problem is it can be affected by diet, whatever that the individual eats, or also aspirin. Particularly, you have to be off aspirin for at least 8 to 10 days before you can do the test. The sensitivity is not that high either. It's only about 33 to 50%. The newer tests, such as fecal immunochemical tests or the immunochemical fecal gut blood test, has sensitivity increased to 60 to 80%. Once they become positive, naturally, you need to go with further evaluation. Still, for DNA testing is a new test that got approved not too long ago, and it looks into the DNA mutation of all these stools, of the stool specimen. The advantage is that you don't need to have special preparation, and you don't have to have any diet or medical restriction. And the same is true. It can be done at home or in the physician's office. However, my personal thinking is that it is relatively expensive at this time, and I hope down the line they will come down in price. CT colonography naturally is a new radiological technique, and it's the radiologists claim that it can detect 90% of polyps that are greater than 10 millimeter, but on the other hand, the accuracy and sensitivity drop down when it's smaller than 6 millimeter, and it misses the flat polyps. The problem, it requires preparation, and it increases radiation exposure. Here are the sample of the CT colonography. This is an adenoma with a polyp. And the same is true with here. I'm not sure whether you can see it clearly. But this is the new test that we have to start thinking about. Flexible sigmoidoscopy reduced mortality by 60% on the left-sided colon. And you can do it in the general physician office. You don't have to go to a colonoscopics or anything, because it doesn't really need sedation or special preparation. On the other hand, it can miss 30% of the right-sided colon cancer. Colonoscopy, of course, is the mainstay in screening procedure because it can reduce 53 to 72% of the colorectal cancer, and it can reduce mortality. There are serious complications like perforation or bleeding, but on the other hand, they are not that common. It's only about 3 to 5 per 1,000 colonoscopies. The interesting thing about colonoscopy, however, it also depends on how rapid the colonoscopics try to withdraw the colonoscopy. If the colonoscopic try to withdraw the colonoscopy less than 6 minutes, it only detects about 11.8% of colorectal cancer, of any neoplasia, and only 2.6% of advanced adenoma. But if the colonoscopist is thorough and deliberate and be slow in moving, taking about more than 6 minutes, it increases to 28.3% and 6.4%. So I think if you go for colonoscopy screening, we just need to talk to these colonoscopists not to move the colonoscopy and not to do it in a hurry, and just they should take deliberate time. Of course, what the benefit of screening, it reduces the colorectal cancer mortality by detecting cancer at an early curable stage, and also detect and remove polyps before they become cancerous. So who should have a screening procedure? In a normal individual, if you're 50 years old, then there's no family history, no history of adenoma or CRC, no history of inflammatory disease. You can do annual stool for a gut blood and also proctosomnography every 5 years and colonoscopy every 10 years. For whatever reason, you can't do a colonoscopy, you can do CT colonography every 5 years. But I'm still skeptical about that test, though. Personal history, if you do have personal history of adenomatous polyp, then you have increased risk of developing colon cancer. So if you have a low risk adenomatous polyp, which is like 2 centimeters or less, or only 1 or 2, you can do the colonoscopy within 5 years. But if you have multiple polyps, then you need to do colonoscopies within 3 years. The same is true if you have family history. The first relative with age who is less than 60 years old, then you need to do colonoscopy at the age of 40, or 10 years before the earliest diagnosis of colorectal cancer. That means if your first-degree relative has a colon cancer at age 40, then you should be doing it beginning at age 30. But on the other hand, if you have the older than 60 years old, you can do like a normal colonoscopy at the normal period. On the other hand, and the same is true with personal history of inflammatory bowel disease. If you have ulcerative colitis, colonoscopy should be done 8 to 10 years after onset of symptoms of colitis. And it's important that they need to do biopsy of the skin, what you call the mucosa, and then after that you do colonoscopy every 1 to 2 years. And as soon as you see any changes in dysplasia, hyperplasia, you have to be calling the surgical consult. And then, of course, if you yourself have a colon cancer, depending on the stage, if you have a high stage, you have to do HNP and TA level every 2 to 3 months. 3 to 6 months for 2 years, then yearly for 6 months for a total of 5 years. And then you have to do CT scan of the chest and abdomen annually for up to 5 years, and colonoscopy in 1 year. And then if there's no change, if you don't notice any polyps or so, then repeat it in 3 years, and then 5 years. On the other hand, if you keep seeing the polyps, then you need to repeat that. Of course, we like to prevent it from having the disease, and what are the things that we should do to prevent? And the thing is that if you have low red meat or processed food, that's the best way to prevent. The diet is much better. The same is true with abstaining from drinking alcohol or smoking. And also, of course, the most important thing is to maintain the body weight and to do regular exercise. This is American Cancer Society guidelines score in risks of cancer. What it means is that they follow about 65,000 women for 12 and a half years. And if these people follow strict guidelines such as maintaining body weight, regular exercise, and abstaining from alcohol and smoking, it reduces any cancer by 17%, and breast cancer by 22%, and colorectal cancer by 52%. So you can really reduce the incidence of cancer if you really are aware of the disease. And one of the things that has been popular recently, is aspirin, and people use a lot, take aspirin to prevent cancer. But the thing is that it's very interesting. It inhibits prostaglandin peroxidase synthase related pathway. And then the interesting thing is that one study showed that it reduces colorectal cancer by 50% in individuals who have high levels of 15-hydroxyprostaglandin dehydrogenase. Unfortunately, we can't do the test on every individual. Aspirin, unfortunately, all the studies have been looking at with high dose, more than 300 milligrams, and then naturally that's a problem because we do see some side effects like bleeding. So currently we don't recommend to take it regularly because we don't really know the dose and the duration that we need to do to find out how effective that is. The same is true with NSAID or COX inhibitor. We know that Sulindac and celecoxib reduces the adenomas in familial adenomatous polyposis. However, we don't really know. We have the same problem of finding the dose, duration, and the drug that we need to take. And of course, we have to be concerned about the side effects of the disease, such as GI irritation, bleeding, and renal toxicity. So there are some ongoing studies. As long as we don't have the conclusive data, we should not be taking that to prevent the disease. Statins have become popular recently, and there are very interesting studies going on because it inhibits cell proliferation and apoptosis and inhibit angiogenesis in addition to the irregular and lipid-lowering effect. The only problem with statin is that the results are not conclusive, but they have found that using statin after diagnosis of colorectal, it may be beneficial. Currently, the large cooperative trial is looking into this and recruiting patients, but like I said, until we get more data out of it, we shouldn't be taking statin to just prevent colorectal cancer. Metformin, the anti-diabetic diet, anti-diabetic medication is also becoming very interesting because it has a direct effect by inhibiting adenosine monophosphate kinase, which affect we call it mTOR pathway, and indirectly it also reduces the insulin. That way we also reduce insulin-like growth factors to prevent the disease. And interesting that in diabetic patients, they claim that they reduce the incidence of mortality of colorectal, breast, and pancreatic and hepatocellular carcinoma. But the problem is the studies are all retrospective. It's not really thoroughly organized study, and so we don't have a real conclusive data. So at this present time, with the same thing, we don't recommend taking them. And of course, there are lots of people who like to take vitamins, and vitamin D is particularly interesting because they found increased cancer in countries that are away from the equator. But the problem is they are primarily observational, and the role of vitamin D supplementation is not thoroughly studied. Selenium naturally is one other drug that people are very, I think, popular and taking regularly all the time. The only problem is that they did have a recent meta-analysis looking at, I think, 8,000 patients, and they found that selenium doesn't really reduce the colorectal cancer. Of course, the other vitamins such as vitamin A, vitamin E, and beta-carotene, we have to be concerned because there are studies that show that they increase the cancer incidence of lung, stomach, and prostate. So we have to weigh those consequences before we think about taking them. And of course, what do we do basically is the most important thing to me is that you maintain the body weight and doing regular physical exercise. Thank you for that. And for next discussion, we'd like to have Dr. Tan to discuss on the pathology of colorectal cancer. As you know, Dr. Tan is a professor at the Singapore General Hospital and